I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, here I'm going to get into the good stuff. We're talking pharmacology, we're talking medications used for the management of blood pressure. All right, first class of medications is the ACE inhibitors. Please, if there's anything you remember here, remember the PRIL. That ending, benazepril, lisinopril, captopril, enalapril, is going to tell you this medication is an ACE inhibitor. So first and foremost, remember that. Mechanistically, these drugs inhibit what's called angiotensin converting enzyme, and that blockade of that enzyme actually stops the production of angiotensin II. Angiotensin II causes vasoconstriction. And remember, when blood vessels constrict, that's going to increase blood pressure, similar to squeezing a hose. That increases the, pressure of the water within that hose, okay? So that constriction of the vessels is going to be very, very important for raising blood pressure. So, by blocking that angiotensin II, we're hoping to obviously cause more vasodilation, where those vessels open up and blood pressure drops. CRAP-H is a good way to remember the most important side effects of ACE inhibitors. C is for cough, so it causes a dry type of cough. Very important to remember that. It can cause renal impairment, but is also used in CKD to kind of delay progression, so that's kind of a little bit of a catch-22, but bottom line, the important thing here is to monitor labs. So creatinine, that's going to be important to monitor, and if that goes up, that could be indicative of renal impairment, and then we would reassess using the ACE inhibitor. But bottom line, we need to monitor that renal function, and the H at the end, we also need to monitor potassium levels. Really, really important. It can cause high potassium. Angioedema is swelling of the lips, tongue, mouth, and it actually can progress into the airway. And if it's a severe case of angioedema, it can block off the airway and prevent breathing. So that's definitely an emergency type situation, okay? So angioedema, that's a good one to remember. Very, very rare, but it can happen. And then, of course, we've got P, which is the pressure drop. Any medication used for blood pressure can drop it too far and can cause too low of a blood pressure, which can lead to dizziness, falls, and syncope type reactions. All right, so summing up a few of those clinical pearls, ACE inhibitors can exacerbate CKD, but also can be renal protective. Lisinopril is the most commonly used medication there. Classic medication cause of angioedema. Again, very, very rare. But if you have a patient with angioedema or with a dry, hacking cough and you think it's medication related, ACE inhibitors are going to be the first place to start, making sure a patient's not on one of them. And then I'll talk about ARBs coming up here, but ACE inhibitors and ARBs, they work on the same pathway in the body physiologically. They absolutely should not be used together. So if you ever see an ACE and an ARB on the same medication list, definitely talk to the pharmacist, talk to the primary care provider. That shouldn't be. Compelling indications. So these are indications that are potentially additionally helpful in addition to lowering blood pressure, diabetes, stroke, coronary artery disease, CKD, and CHF. All right, let's move on to ARBs. So that's angiotensin receptor blockers. And I alluded to the fact that angiotensin 2 causes vasoconstriction. So these actually don't reduce the production of angiotensin 2, but they actually block it from binding the receptor. So they block the physiological action that way. Okay, so again, causing that vasodilation by essentially blocking something that causes vasoconstriction. I mentioned don't use these agents with ACE inhibitors. Keep an eye on that ending. So if you see something with an ending of sartan, S-A-R-T-A-N, you can have a pretty safe bet that it's an angiotensin receptor blocker. Losartan, brand name Cozar, is probably the most common agent I see used. Again, clinical pearls here, absolutely very similar side effect profile to ACE inhibitors. So if you know ACE inhibitors, you can easily know ARBs. Now, the one exception to that is ARBs do not cause that cough, okay, or very less likely to cause that cough. So in practice, if we have a patient that starts lisinopril, they get a cough, we'll typically switch them over to an ARB like losartan. All right, moving on, we've got diuretics, specifically thiazide diuretics are used for hypertension. Loop diuretics, which I'll talk about in heart failure, those aren't typically used just straight for blood pressure. They're typically more so used to promote fluid loss and help manage edema type things. Now, the thiazide diuretics, most common medication here is hydrochlorothiazide. Mechanistically, this works in the kidney. It blocks sodium reabsorption back into the body, okay? And by blocking that, you actually also promote the loss of fluid. Fluid and sodium go together oftentimes, and so they both leave the body, obviously go into the bladder and out through the urine. And with that reduction of fluid, with that reduction of sodium, we can lower blood pressure. We do have a couple compelling indications you often see thiazide diuretics used for, like CHF or edema, and potentially stroke reduction there as well. All right, memorable adverse effects. If you remember HerFed, that can potentially be helpful. I would say number one, hypokalemia. It can lower potassium levels. It may worsen gout. That's an important one to remember, elevated gout. Renal impairment, so it can cause dehydration, and you may see a rise in creatinine and a subsequent drop in creatinine clearance, which is a measure of renal function. Frequent urination. If you understand the mechanism, you will understand why that makes sense, right? If we're causing sodium water to go out of the body, it's got to leave somewhere, and it leaves from the bladder. So if you've got more fluid in the bladder, you're going to have to go to the bathroom more and more. It can contribute to erectile dysfunction, and then I alluded to kind of dehydration, and that can be associated with renal impairment as well. Next class of medication, we've got calcium channel blockers. There are two kinds of calcium channel blockers. There's the non-dihydropyridines and the dihydropyridines. Non-dihydropyridines work on the heart as well as the vessels, and those are going to be typically used much more often for something like atrial fibrillation to slow the heart rate down, okay? The dihydropyridines, if we're talking about hypertension management, that's going to be the most commonly used class of medication, with the classic medication being amlodipine. You're definitely going to see that all day, every day. If you're in, primary care, in a hospital, whatever, patients that have hypertension, very commonly used medication for sure. As the name implies, they inhibit calcium channels, which prevents ion transfer, and this preventing that ion transfer actually relaxes smooth muscle in and around the blood vessels. So if we relax that muscle, they don't constrict, they more dilate, open up, again, lowering blood pressure. Other than hypertension, you will see these meds used for things like Raynaud's, angina, maybe rarely for headache prophylaxis. That's probably more so the non-dihydropyridines, but they can be used as well here. Number one adverse effect is edema. Okay, very, very important, and it's not due to fluid retention and actually retaining. It's basically a way of caused by fluid redistribution. So you're likely to see an increased swelling around the ankles. So that's something definitely to assess. I've seen many nurses catch this, where they note or the patient reports that the ankles are swelling. And if you go back, look at the medication list, you may see within the last week, 2 weeks, month, maybe they started on amlodipine or had an increased dose for blood pressure. Okay, so making sure that we're identifying those new clinical signs so we can assess if medications are contributing to those issues. Really, really important. Orthostasis, again, all blood pressure meds can drop blood pressures too far potentially. Nifedipine you may see used in pregnancy a little bit there. Again, the dihydropyridines don't really affect heart rate too much, but if you've got some of the non-dihydropyridines on board, like diltiazem and verapamil, that's something you got to pay attention to for sure. Definitely a first-line agent as far as blood pressure goes, as well as ACE inhibitors, ARBs, and thiazide diuretics. I did put them on here. I'll probably talk more in depth about these. These are the non-dihydropyridines, verapamil, diltiazem. Again, more so used in atrial fibrillation, can drop the pulse, can cause edema as well as constipation as far as the adverse effect profile. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse. Next class of medication is aldosterone antagonists. Spironolactone you see way more often than eplerenone. Spironolactone can be used for heart failure as well. Spironolactone, really pay attention. It can cause hyperkalemia. So if we use this in combination with ACE inhibitors and ARBs, we may really exacerbate that risk for elevated potassium levels. So really important thing to monitor there. Aldosterone antagonists are also classified as a potassium-sparing diuretic. So understanding that name, potassium-sparing, that might help you remember the hyperkalemia risk as well. Gynecomastia or man boobs, so enlargements of the breasts in males, that can obviously be a very bothersome and troublesome adverse effect if you're giving spironolactone to a male patient. So pay attention to that if you hear a patient report to any type of, tenderness, growth, that type of thing. Spironolactone is notorious for that adverse effect. Pay attention to renal function a little bit there. We're going to monitor renal function with this medication, and then, of course, that potassium as well. All right, beta blockers. So I talked a little bit about the autonomic nervous system. So if you want a little refresher on kind of that fight or flight response and where beta blockers may fall in here, that might be a little bit helpful there. But essentially, beta blockers, specifically the inhibition of beta 1 receptors, cause the heart to slow and blood pressure to drop. Okay. Now, recall beta 2 inhibition can lead to the closing of airways and difficulty breathing. So these drugs basically block the receptors, which prevents epinephrine and norepinephrine, which I talked about in the autonomic section. It blocks epinephrine, norepinephrine from binding and increasing heart rate and increasing blood pressure. So that's what beta blockers do. Metoprolol is probably the most commonly used beta blocker. It is pretty selective for beta 1, which is what we ideally want, because if we block beta 2, we could exacerbate breathing difficulties. And that's actually kind of one of the precautions with this medication is it can increase the risk for asthma exacerbations or breathing issues. So pay attention to that. Some of these drugs, going down to the weeds a little bit, some of these drugs are worse than others. Propranolol kind of being a classic example that has more beta 2 blocking action. I wouldn't stress about that too much. I would just say as a class, recall that beta blockers can potentially worsen respiratory diseases like asthma and COPD. It's important to avoid abruptly stopping. We can actually have rebound hypertension. So when we take patients off these medications, we tend to taper them down slowly. So if you're talking to patients and you notice their blood pressure is way up or it's spiking, definitely a good idea to ask about adherence to their beta blocker. Did they just recently stop taking it, for example? All right, adverse effects. Pay attention to sleepiness, and we need to monitor blood pressure, obviously, but pulse as well. Beta blockers can absolutely drop the heart rate and drop it too far. So pay attention to that. Need to monitor that. And, if you're getting less than 60, less than 55, definitely a good time to notify the provider and just to make sure that they're comfortable with where the patient's at with their pulse. There is a rare effect that can mask hypoglycemia. The one effect that isn't blocked by beta blockers is sweating. So patients with diabetes, if they're experiencing hypoglycemia, they still should feel sweating as part of their body's notification that they have low blood sugar, but they may not feel some of the other signs and symptoms as well in that situation. So again, usually not a crazy big concern, but if you've got a patient that's having frequent hypoglycemia, they may not be able to recognize it quite as well if they're on a beta blocker. So definitely something to think about there. And then they may induce or worsen erectile dysfunction as well in males. That selectivity is important. I mentioned the propranolol example. Propranolol, nadolol, those, non-selective beta blockers, if you will, block beta 1 and beta 2, and they are more likely to worsen asthma. Okay? So that's an important thing to remember there. Compelling indications for beta blockers in addition to lowering blood pressure, angina, CHF, right after a heart attack, you may see these medications utilized and chronically as well, potentially. And then atrial fibrillation. These medications slow the heart rate, so they may be beneficial there. Other, potential uses for these medications. I'm not going to go into a ton of the details here. I put this on there basically more for your educational purposes. All right, moving on, we've got central acting alpha-2 agonists. The most commonly used medication here is clonidine. So stimulation of alpha-2 receptors in the central nervous system actually reduces the sympathetic nervous system action or sympathetic outflow. Again, kind of reducing that action of epinephrine and norepinephrine, which reduces vascular resistance again and the heart rate. So drop the heart rate, you drop the vascular resistance or those vessels closing. That can lower blood pressure. Beta blockers as well as central acting alpha agonists, these are not first-line medications for hypertension. They got a lot more adverse effects. They can cause drowsiness. The central acting agents can cause drowsiness, dizziness. Dry mouth is a big complaint I get as well, particularly in my geriatric patient population. There are other potential indications with these. Opioid withdrawal. You may see ADHD. That's more 10x or guanfacine. And similar to beta blockers, we really don't want to stop these medications abruptly. They can cause significant rebound hypertension. Another class down the line, vasodilators, direct-acting vasodilators. Hydralazine is probably the most common medication I see used here. Mechanism of action is not well understood, but basically exerts a relaxation effect on those blood vessels, and that opening of the blood vessels drops the blood pressure. Pay attention to patients with lupus with this medication. It may worsen or contribute to those type of symptoms in that disease state. One of the biggest reasons why hydralazine isn't utilized very often is it has to be dosed frequently. So that can be a major issue and a pill burden type of problem, especially when you're talking about a chronic medication that's likely to be taken for years and years and years. Minoxidil, I hadn't mentioned yet, but it actually can be used for hair loss. Brand name is Rogaine there. Rarely in heart failure may see the hydralazine nitrate combination used in patients that don't tolerate ACE inhibitors or ARBs. All right, nitrates, medication class not used hardly ever for straight blood pressure lowering purposes. It's really got a specific niche here, which I'll get into. Isosorbide mononitrate, IMDR, and then we've got nitroglycerin or NitroQuick. Nitroglycerin is typically taken under the tongue for angina. It's generally not going to be used to lower blood pressure, but it can have kind of that additional effect if you've got a patient that needs medication for angina in like isosorbide mononitrate chronically. It can help reduce blood pressure there as well. The nitro for acute angina attack, it's dosed every 5 minutes, and obviously this is for angina, acute chest pain. Obviously we're worried about a heart attack here, so if there's any doubt in that chest pain and what's going on with the patient, and there's any suspicion it might be a heart attack, obviously that's an emergency situation right away. The long-acting agent is IMDR. The quick-acting agent is nitroglycerin, sublingual, or NitroQuick is the brand name there. There is one kind of thing that you should maybe pay attention to. Nitrate tolerance. This can develop in 8 to 12 hours. So typically, we give IMDR, that chronic medication, once in the day, and then we allow that medication kind of to be totally clear to the body, and that gives us that nitrate-free period. Otherwise, we develop tolerance. So basically, the body gets used to having that drug around, and you need more and more of it to produce the same effect that we want. Whereas if we let it totally clear the body, the risk for that tolerance goes significantly down. One major drug interaction with nitrates, absolutely commit this one to memory, is PDE5 inhibitors for sexual dysfunction. So medications within that class are sildenafil, brand name Viagra, tadalafil, brand name Cialis. Okay, so those erectile dysfunction medications, absolute contraindication there. Great drug interaction to commit to memory, and something that I've definitely seen show up on pharmacology and board exams. Alpha blockers. These can be used for hypertension. They are very rarely used for hypertension. They cause significant dizziness, significant orthostasis, almost to the point of syncope, passing out if the dose gets too high. So that's a big problem with these. Mechanistically, how they work, they block alpha receptors. Alpha receptors are found on the vessels, and typically under normal physiological circumstances, epinephrine, norepinephrine are binding those alpha receptors and causing vasoconstriction, like in a fight or flight type of response. Well, alpha blockers block those receptors, prevent norepinephrine, for example, from binding there, and ultimately causes smooth muscle relaxation. Now, more specifically, with the vasodilation, that drops the blood pressure, but where you see alpha blockers used more often, particularly the selective ones, are medications for BPH. They can help alleviate symptoms of urinary retention. They cause opening of the ureter and help patients go to the bathroom easier who have BPH with urinary retention. You may see these used at night. This is to help kind of reduce that risk of orthostasis, dizziness, and falls. And then lastly, if you've got a patient with an eye appointment, an eye surgery, cataract extraction, things of those nature, definitely good idea to make sure the eye doctor gets the medication list. If they've got an alpha blocker on that, the eye doctor is likely going to want to hold that, or at least address the use of that alpha blocker, because there's a risk of what's called floppy iris syndrome. So good one to remember there with alpha blockers. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded 101 Nursing Pharmacology Review course.